So I have the patient on the table, so I have a little platform to work.
Okay.
And I'm going to turn the head and no, just normal cluster. Yeah, yeah.
Głowę przykleić trochę
Yeah,
do...
and I'm gonna,
Taki zwykły, cienki.
yeah. And this we can move down a little bit. Okay. Plaster. Bigger, something like this, yeah. We're using a laser, so we have eye covers, even though it's unlikely to cover cause, but for protocol we should put eye covers. This down a little bit, yeah, that's good. Okay. Good. This is very good, this plaster. Okay. Good. Okay, good. Now. So I'm going to tape from the top of the head, not here, because if I tape here, which everyone does, then everything falls on the ground. So it's better to tape from here, this way, just to put to the side and avoid the eyebrow, not to tear the eyebrow off of the patient, because just to hold the head like this 1 or 2 times, and this is enough. Good. So I've got that here, and I've got this here, just to hold the hair back. Now, now, in the United States, we would always use a facial nerve monitor, but in Europe, it's not routinely done, no. So, just for standard protocol in US, put facial nerve monitor. In some centers we put it, but in low-risk procedures where we can see the facial nerve, we wouldn't put it. So that's it. So now we can paint everything and make sure it goes down the ear canal, okay? Good. I'll show you here. I have blue laser. This is awesome. Oh. So this is blue laser, and I'm putting the settings on ear, and I'm going to set it for crura for now. It's 100 millisecond pulse width, and I'm going to modify it a little bit, treat, and I'm going to modify it to a continuous at the beginning. Okay, so we're going to use a 2 watts power continuous at the beginning, and then later for the foot plate we will change it over to a single pulse of 100 milliseconds. First thing to do always with these oculars are out. When they're out all the way, they're for working without glasses. When you work with glasses, you need to put these in all the way. Then to check with glasses, they should be set to 0 and let the glasses do the correction. Okay, good. So this is set nice. Now, the next adjustment that I like to do on a Zeiss is to move these handles as forward as possible, because the Zeiss put the handles more back than on a Leica system, and it's better to have these loose and put them as forward as possible. And now I have a closer simulation to the Leica setup, which is preferable for otosurgery to have this forward. Otherwise, when you're going to grab your handle, you're pulling your hand way back, and it's not comfortable. There, so now this is set up forward. And then a little bit about zoom focus. We have so check, my working distance is usually around 200, as close as possible. And then we have, okay, relative, good, so I have to pull out a little bit. Can we put the room lights out and these on, and you can leave these on,
Brudne światło.
for them, but took these out. And the reason for putting the room lights out is that my eyes dilate, my pupils dilate so that I have better dark vision. Let me see, aspirator, sak?
Ssanie.
Sania, good. And normal żernik za ucho.
Big.
Yes, big. So always examine the ear before any operation. Just to see what's going on. Now, I can't remember, did she have a previous otosclerosis surgery?
Yes.
She did. Okay, so this is a revision, and I see, let's look at the very back of the eardrum. We have to be aware. Okay, so you see, this is interesting. See, she has a little area of monomeric drum from a previous otosclerosis surgery, okay? So there was more than likely a little bit of, maybe residual perforation that grew in as a monomeric drum,
Okay.
because the fibrous layer in the center didn't retain. Okay, so we have to be aware of that. Not a problem, but we'll put something to reinforce it. And I think the question is that a prosthesis?
Żeby pani widziała inne. Okay.
It almost looks like there's a prosthesis there. You see, look. See, the igua, bent igua.
I can see it, I think.
You see?
Yes.
Igua rosena, you call it? Igua rosena, or? No, this is rosen knife, but it's okay. Igua rosena is a gentle curve pick.
To jest takie ostre na końcu proste.
Yeah, so this is a straight pick, but it's okay. So look, you can see this is actually a foot plate pick, but
Yes.
it's okay. I think this could
is.
be a prosthesis
Okay.
right there, okay?
Okay.
So it's very important we look first, because I think that could even be a prosthesis. So I'm going to use a keyhole incision. And it's basically going through the ear canal, but rather than making incisions in the ear canal and cutting the skin of the ear canal, disconnecting it, which causes a delayed healing because you have to create flaps and that's to heal in, I'm going to access the ear canal directly this way, okay? So a very small incision through here. So first thing I'm going to do, I'm going to give, let me see the bupivacaine. So you see, this is the angle I have to be, all right? So it's basically right there. So the first thing I'm going to do, I'm going to give her a block. So this is going to help with the anesthetic, especially if you're monitoring nerves, which we're not in this case, but if you are, it's nice. So here's the nerves come in from behind. You have the great auricular nerve, the occipital nerve in this area. So I basically give a bupivacaine block down towards Erb's point, where those nerves come out. Just being careful not to go, always withdraw before you inject, because you can hit the occipital artery and then you don't want to give an intra-arterial injection of bupivacaine. So here is the mastoid tip, and just not to paralyze the facial nerve with a long-acting agent, just to be a little gentle here. And then a little bit here, again, in the skin area. And she will also have a nice anesthesia for about 12 to 18 hours. Can I have a little more? Jeszcze. Okay. Get the hair out of the way. And because I'm going this way, you can even see where we're going. I'm just going to give it here, you know, there's a little bit there, and it's going to puff that up a little bit, give an anesthetic, and because I'm not entering the skin of the ear canal, there's no reason for me to do extensive ear canal injections. Okay, just here, and then puff this up like this. Here, take careful of the needle, and watch here as I push it in. It's going to go down the ear canal this way. See, by pushing it this way. See, I pushed it down, and it goes all the way down the ear canal. See, I'm going to watch it. So it blanched the ear canal this way, just by pushing it. So now I've given a good devascularizing injection of the ear canal from behind. Maybe a little more. See, a little more. Jeszcze.
Jeszcze jest niepłynne.
And watch. So I can put it here and see here. And you can watch it go down the ear canal. A little more here and nicely down the ear canal. Maybe a little more here. There we go. Not to get into the middle ear. Okay, good. Take that back. Okay, let me get this. Oh, okay, good. Now, let me see the needle monopolar, the monopolar. So you see, again, I can see where my target is. I can see I'm going to go right down this way. And I'm going to make the minimal incision.
So this is it.
Yep, just in the crease here. Oh, it's not on? Okay. Mm-hmm. Okay. So you can see our trajectory.
Yes.
Should be okay? Okay. My fingers here, I can feel, I'm just in the crease, right here. And then make it just big enough to work. And if it stretches a little more, it will stretch a little bit more. But this very small, okay. And I can feel, I want to go just here and under the, and stay under the cartilage so we have the minimal amount of tissue to elevate. Suction. I have it here.
Okay.
I have it, okay, it's okay. And we have access here to, I'll take it back in a second. We have access here to we have here to cartilage. Let me see the bipolar. Nice little artery there. Let me see, where's the pedal? Hold on. Okay, see? I think in my set, do I have on my set a shorter one of this? I think I do.
A jeszcze coś profesora na narzędziach są krótsze te ssaki.
This thing, yes. Look on my set. I think there's a short one. This one here. No, no, no. On the tray.
Here, this one.
No, no, no. No, no, no. On that.
No
Look.
one of this.
No, 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 no. This piece, this thumb hole piece. You see? Right there. No, no, no. It's right there. I see it. I see it.
You are
Lift
thinking about this.
this piece. Look, look, look there. Look.
A, łącznik, to jest niebieski.
No, no, no. Look right there. Look. Lift that up. That. There you go. Yeah, yeah. Because this is very long, you know.
Okay.
So look, we just have the minimal, okay? Yeah, see? Yes, the same one. Good. Yes, you see? Much better. And the other thing we can do, watch, we can cut here. Watch this. Actually, this is not so bad because,
Sometimes it's too big, yes.
yeah, sometimes it's too big. So here, I have here, right down here. I have here, okay, here. So I want to minimize the elevation of, I want to minimize what's in my way. So the stuff that's going to be in my way is going to be anteriorly. So I feel here, and this is a very nice bipolar to use, a very, very sharp pointed bipolar, because it also acts as a dissecting tool. So here, I feel the conchal cartilage, and I go underneath the conchal cartilage to get to the bone, okay? So here I'm under the conchal cartilage, and now I'm going to be at the bone here with the minimal amount of tissue to elevate out of the way. So staying to hit the ear canal from this way, this direction, and I can widen my access to. And the nice thing about this technique is that you're not limited to using only these specialized micro drills. You have enough room to drill with the normal otologic drill system, to drill the scutum. Okay, suck. Sanya. Okay. So I'm basically ending up here, okay? And then, good. Now let me see the monopolar again. I can feel the bone. I just want to cut right down to the bone. Oh. I'm completely down to the bone now. Okay, good. Nice and widely to the bone. Good. Now let me see the self-retaining retractor. Otomat? What do you call it? Otomat or?
Retractor.
Retractor.
Znaczy tak. This one?
No, the one with the paddle. The one with the paddle.
This
The
one?
one with the.
Ten jest większy.
Let me see. No, no, the one with the lip. There's the one with, yes, that one. And do you have the other direction of this or only?
Z drugą stroną.
Yeah, that's it. That's it. Good, good. So this side. You see, this is a very nice retractor for this because it goes right down the ear canal. Okay, look.
Yes.
And I have a nice elevation here and there. Okay. So I'm going to begin with this and then we'll get it in there deeper once everything is open. Okay, now suction. Now I need my duck bill. So the question is, do you have, on my instruments, I have my duck bill.
Teraz u profesora jest ten taki duck.
Yeah, my,
Taki pani.
yeah, oh you have it, good, yeah. So this is the duck, okay, good. So this is the small duck, and the small duck is perfect, you see? So we're right here. I can even get this one in to this soft tissue better, you see? Look.
Yes.
By saving that soft tissue and not going to the bone, I have a better elevation. Okay, good. So very nicely here. And we can see we're in the ear canal now. Hold on. There. Okay, okay. Everything is good. Good. Yep, everything's very good. Bipolar. A little more. So there's no reason to give myself a narrow space, you know. I can elevate everything here. Okay. And even here, no problem to elevate here. Okay, here is the bone. This is the tympanomastoid suture line. So I can also hold this for a second. Just take that. No, the duck. Okay, so here, the tympanomastoid suture line. I can open this up a little wider. And here's the tympanomastoid suture line. Can open that up and get that elevated off with this instrument, see? I'm gonna turn and look here. See, it's nice also, this very small bipolar. Here's a little bit of tension here, so I can, this little bipolar to dissect, see? To dissect bloodlessly. If I keep it together, also it dissects also nicely. Here. I want to try to minimize my entry into the ear canal. What is that? Okay, good. Good. Let me see the duck. Kachka. And then I'll go now to one size smaller suck. Manje, mniejszy suck. Mniejszy suck. Mniejszy suck. It's like diminutive, miniature. So good. This is good. So see, nice. And I'm going to go all the way down here, see? And have a beautiful view. Yes, you can accomplish this kind of angle and view with an endoral incision. However, I would argue, having used all the various approaches, endoral, transcanal, that this gives you more light and a better view than also an endoral incision, and faster healing than an endoral incision, because there's no entry into the ear canal at all. See? Now let me see the bipolar. What's holding me here? A little bit here, no? And the goal is to try not to enter into the ear canal. Here's a little piece of cartilage, you see? So for example, I'm going to take a piece of cartilage because there is a little defect there, and I'm going to take advantage of this cartilage and close it. Let me see the bipolar. So,
You
bipolar?
will take it from this place?
Bipolar, yes.
Okay.
Because instead of taking tragal cartilage, I will take this. So I have chondral cartilage right here to rebuild the end of the annulus, posterior superior ear canal, where it was removed. So I can put some, and take some of this cartilage. Let me see a piętnaście.
15 teraz ostra.
15. Here, look, here's some perichondrium, here's some cartilage. We have nice stuff to reconstruct right here. Okay, let me see small pincetta.
Pętletę małą.
Good. Pincetta.
Najwyższą szpatułkę.
Do you have not an anatomic, small anatomic?
Małą anatomiczną.
Yeah. Good, that's better. Take a look. Okay. Good, good. So we can hold that, keep that, save that. Good. I have something here. I have some tissue, more than enough tissue to pack the, stapedectomy site. Okay, good. Suck and duck bill again.
I kaczka.
Now I can zoom up a little, and you see we have a beautiful view into the middle ear. I'm going to get pretty close now to the annulus. Ductal. Let's see. I'm going to pull out a little bit just to get a little better depth of field. Sometimes when you have to realize when you're working with a microscope, the higher your zoom, the less your depth of field. So, go all the way down until I feel it go down underneath the annular ligament. See, now I feel it, and I don't want to enter the eardrum. So I'm going to go down carefully and feel. Let me see the rosen knife. Yes, the Maui Nush Rosena. And it's nice to take a rosen knife and, hold on, and to see it go down over the end. So here it is, and it goes down, okay? So down over the end. You know that you're lifting now the annular ligament out of position, okay? There's the annular ligament, you see?
Yes.
So by feeling it go, then I've identified the annular ligament clearly. Now let me see Igor Rosena. I'm seeing, now I'm going to zoom up a little bit because I know where I am. And there, I've elevated, this is the annulus. There is where the chorda is, or was, let's see. Tiniest little hole, but that's nothing, okay?
Okay.
And let me see now duckbill. So now carefully, now that I'm in the right place, okay? Now I can elevate the annulus carefully without tearing the skin, okay? You have to watch for the annulus and see. There's the annulus being elevated. And elevate this lower stuff also, because otherwise it'll tear. So here we have it nicely opened. Here too, all this can be elevated. This too, not to get a tear. Okay, and here. And then we have to keep this up out of the way. So how do we do that? Two ways. See? One is I'm going to elevate more of this here and elevate it off of this bone. There is a joint here. Sometimes you have the tympanomastoid suture line on the front, and you need to elevate it off of that also. But I think we're okay. Yeah, so this is the front of the ear canal. So what I'm going to do, I'm going to put the retractor in and suck the ear out of the front this way. Just suck the air out. You see, look.
Yes.
And put this in deeper. And there. Okay, see? Now this is pushed up against the front wall of the ear canal, and this is now elevated up here. And we see everything very nicely here.
Yes.
If we needed to, this is the front wall, sometimes we have to elevate this up and drill off the front of the tympanomastoid suture line, but I don't think it's going to be necessary here.
Okay.
We have very nice elevation here, and we have very nice elevation here. And another thing I can do, I can also bipolar this, watch. Bipolar. I'll see the air came out. I'll do it again. I'll slit this here and like that, or to put something also, it's possible, and also to, give me the other one that has the teeth. Watch. Sometimes it's easier just to use the teeth. One. No. With the teeth on both sides. Yeah. Yes. No, and no, I'll do this. I'll separate this. Let me see. Watch this. I'll separate this more. I'll separate this to the other tympanomastoid suture line. And push this up forward. There's the tympanomastoid suture line there, and I'll push this up forward this way. There. See? Up there. See the duckbill?
Yes.
Here, you see? Here. It's still stuck here, that's why. Ah. And some patients have a very big tympanomastoid suture line. You can even do a canalplasty through this. You know, you don't have to. There. So that's now more separated. There we go. And now I'll take that other retractor back.
The same?
Yeah, the first one I had.
Teraz ten, co był wtedy. Tak.
Good. I have to get. I would like to. I have to fashion one that has teeth in it at the end here. You see, so that it holds down. It's okay though. Okay, there. See, now it's up nicely.
Yes.
Now everything is out of the way, and even here. And let me see Igor Rozena. And for proper exposure for stapedectomy, you should be able to see even the short process of the malleus. We'll see here, and oh, I put the light on maximum. Let me get the light. Oh, it's okay.
Just a moment.
Yeah. See there, and now look, here is the short process of the malleus. Here is a small, let me see, the small Mikronojitsky. It could,
Now is better the light?
yes,
Okay.
Mikronojitsky. Hartmana, Mikronojitsky Hartmana. Good. See? Okay. Okay, good. Igor Rozena. Very nicely, I have, here's undersurface of the drum, here's the malleus, short process, here is the short process malleus, here's the chorda under here, so I don't see exactly. This is a revision or first? I don't. It looks like there was, because there was some operation. But they didn't really take much of this bone, you know.
Yes.
They're still very nice. So now let me see the micro drill,
Teraz wertarka.
Vertarka, and I have a good. Yeah, I see there's scar tissue there also. So, and the biggest of the burrs that she has available for this. Let's see. Okay. Now, I'm using the micro drill, but you can use a regular drill. This is a very small burr. Does she have a bigger burr?
Czy mamy większe wiertełko? Większe, okej, ten moment.
And this patient, so the history, this patient has mixed hearing loss, but is a cochlear implant candidate at the current settings of her hearing. But we are going to try to do a stapedectomy to see if she gets reasonable levels of hearing with conventional hearing aid for some time. If not,
Pokażę, jakie mam.
we're going to go to cochlear implantation.
Proszę pokazać. Wydaje mi się, że one są... Profesor, just check which
Biggest
one.
one possible.
Jakie jest największe po prostu?
The biggest one she has.
Największe to chyba to żółte. Zaraz zobaczę. Ja pokażę i...
You can give me back what you had if you can't tell.
No to dobra, to niech pani daje.
You can give me back what you had. It's okay. It's okay. It wasn't so bad.
Pokażę takie.
Okay?
Czy jest większe?
No, this is give me back the other one. It's okay. Yeah, it's okay.
Tam to jest największe.
You see, the other advantage of lifting this is we don't have much in the way of bleeding because we're not bleeding so much from the edges, maybe a little bit here, but we're not bleeding from cut edges of skin. So our bleeding is easily controllable and predictable.
Okay, here it is.
Okay? Give me just a little water.
Troszkę wody teraz.
Um, Oh no, hold on. It's okay.
It's not good.
No, it's all right. Hold on.
Widzę też.
Hold on. It's okay. Yeah. It's no, it's not. Hold on. Now it's in. It should go in just to where the color is gone. Yeah, yeah.
Było za słabo wciśnięte.
Yeah. Just to where it is. Yeah. Okay. Now it's better. I have the other burr, a regular burr, which would be much faster, but I have a second case that I want to use it, so I don't want to use the drills. Do we have two drill systems?
A mamy dwie wiertarki, czy
Or only
jedną?
one?
Jedną.
Okay,
Only one.
so we will use this for now.
A do drugiego?
No, it's okay.
Będzie inny kabel. Aha, to ten kabel będzie. But to the other operation you want the same drill?
No. I want the regular drill, the DNR is regular.
Wiertarkę, tą waszą,
Yeah.
no.
Yeah. You see, I have plenty of room to work. So like I said, you don't need the specialized drill system to do this outer bone work. And even if you have a very low speed attachment, you can even use a regular drill system to do footplate work, though this is nicer. And I usually use a laser for the footplate work anyway. But this wide opening here gives you access much wider than with a transcanal exposure. Okay, I can see the chorda under there. Preserve the chorda, take this back. Get a little more off the back here. Zoom out a little to get a little more depth of field. Okay, good. Here's the chorda. Nothing wrong with this. Is tympanic bone, all this, so I'm not going to get into the posterior tympanotomy here. It's okay, and even if I do a little, it's not a big deal because we can easily take some bigger piece of cartilage and reconstruct this. There we go. I start to see the stapedius tendon already. I'll take a little more here. Maybe enough, let's see. The only disadvantage of a cutting burr is that you can't change its direction. So, you know, if it skips, it may skip into your chorda. So actually, I take it back because with this system, the micro system, I don't believe you can change the direction either. I could be wrong, but I have to check that. Because this is a Bien-Air micro, I believe.
Yes.
I don't know if you can change the direction. I have to look that up, so don't quote me on that. But with a conventional system, you can change the burr direction so that if you move, you don't jump into the structure. See here, ideally, I would want it going counterclockwise because then if I skip to the end here, it's going to push me back this way. If I'm going clockwise, I can skip up and over the top and injure the chorda tympani. So with the diamond burrs, you can change the direction to your advantage. But with the cutting burr, you can't change the direction. You can, but it's not efficient to use the instrument that way. Okay, so let me see now. There appears to be the stapedius tendon there. Okay. Okay, let me see Igua Rosena. Thank you. That's the pyramidal eminence and the stapedius tendon here, this right here. I'm going to crack this bone off gently. Let me see, łódeczka. Do you have łódeczka? There it is. I don't have one on my side, but do you have one on your side? Or you can give me the duckbill. Duckbill. Yes. Just crack this a little. There. Okay. Okay, there, and you have it?
You have a spoon if you want.
Yeah, let me see.
Dobra, to łyżeczka.
Yes, very good. Okay, there we go. Okay, there we go. Igua Rosena. Get that bone out of there so it doesn't cause its own fixation, but
Okay.
it won't, but okay. There it is. Funny, right? There it is, and that. Gone. Okay, good. Now, look, very nice. You. Okay, let me see one size smaller suck.
Teraz rozmiar mniejszy stanie.
Okay. Do we have a little piece of spungostone?
Malutki kawałeczek spongostanu.
I'm gonna put a little here because it's just this little blood is running from here, one little place here. Can easily stop it. Right there. Actually, instead of the spungostone, give me the bipolar.
Dobra, to jednak bipolar.
It's all right. Oh, the pedal. Okay, no problem. Now it's done. Good. That one? Good. Igor Rozena? Good. So have to see what they did here. Not so sure what was done. This was just a reflection. I don't see much done here. Maybe they did a stapes mobilization, you know, because I can't say that there was a stapedectomy done.
Okay.
You know, there was an incision appropriate for stapedectomy, but there's not really a defect appropriate for stapedectomy. So the mysteries never cease. Okay, so now we have very nice here and here. Let me see the łóżeczka.
Łyżeczka.
Okay, a little bit off of here. They're a little funny. Let me see. See, they're bent back, but okay, that's good there. Okay, good. Now, what I'm going to do next, first I'm going to cut the prosthesis,
Okay.
and then, I mean, I could let's laser first. We're going to laser the.
Okay, laser.
So, I'll show you here now. The fiber I gave you over there. Sorry. And you can give it to us here, and then I'll connect it to. It's okay. You actually can reverse the direction, it appears, on that. Don't worry, just take the whole thing out. Yeah, don't squeeze it. Yeah, sorry, it's good, good. Now, don't clip it. So don't fix it or fasten it to anything, because it'll crack. Just let it sit loosely, okay? Let it sit loosely. Here, hold on. Just open and let it sit. Hold on, no, very careful not to. Here, just take the end. The end, right. Hold the end and let the rest just fall. Yeah. Now, this goes in. Hold on. No. Here. Take this, unscrew that. Unscrew that. Good. Good. And this, goes in here and good. Now just leave it nicely, gently. Let's see this, so we can see that. Good. Now hit standby. Now it's ready. Don't worry, I won't shoot anybody in the eye with it. Take it here, good. And I need the pedal. This is pedal here. Okay, I'm going to move this. I'm going to move it here. And you can put the pedal right here. Now, yes, I have it on and ready. And in principle, we're violating basic safety. Laser, Sandy, you shouldn't put it on yet, but I see better if I see the light. Let me see this handle. Good. So I'm going to put it in like this. That's it. You know, can you move to the, sorry, camera, that's all. You can come this way. You know. Okay, here. So, so it goes in like this. Push this, and I can see a little better. Okay. Okay. So this grips it, so I loosen it. It's a dimed system, and it's better to have it come out the end first, okay? Find the end and find the opening. There it is, okay? So I see it. Okay, it's coming out. There, okay? So you want to see it come out first. Again, don't do it with the light on, but I just want to demonstrate it. Now, there are tips for this, but the easiest thing to use is a suction catheter. And I will take this suction catheter, and you can check to see first if the suction catheter is big enough or not. So this is big enough, it goes over the end. So then I will place it over this way, and I'll place it into the hole. There, okay? So now I've got it coming through, and I want to make the turn. So there. So at first you feel a little bit of resistance as you make the turn, but then once I have it in place, then I can advance it. I can feel you make the turn, and then now we have it, okay? So this is a very good laser handpiece, is one of these disposable type or even non-disposable type suction catheters. Sometimes with the bigger, this is a 0.4, so sometimes with a bigger one, like the 0.6, it doesn't come so easily, so you have to either straighten this out a little bit or use the gently curved delivery. But 0.4 is the preferred one for stapedectomy, depending on the technique. So I like that. So this is all set. Just leave this here, ready to go, okay? So now I'm going to come this way. So now I have the fiber and then this suction. And you don't want to clip this fiber to anything because it's very fragile, it'll break. There's a tendency to clip wires, but that's normal, that's sort of normal protocol, but don't do that with the laser. Just let it float freely. Okay, so now I have the laser, and I just want to check everything on some benign tissue to make sure we're in a good position, everything is good. So I'll just come over here and just to see if we're estimate how my, okay, it's working. I can see that it's working. Okay, no problem. Okay, it's not too strong, not too weak. So I'm going to use this to get rid of some of the soft tissues and to open up a course towards the foot plate. Okay, so I want to see the foot plate. So here's the foot plate, and I want to just open some. See, I can introduce it a little longer. Hold this. hold this piece and push it a little bit longer. You don't want it too long because then it's too flexible and you can't stabilize it. But this is very nice, just like this. Here, where is my, okay. Yes, I'm blocking my view a little bit so I can come around like this to see a little better. So good. Okay. You can see, I want to see the foot plate. Okay, let's see, a little more scar tissue here on the back can be taken. I don't want to disarticulate the entire foot plate, I don't want to disarticulate the superstructure yet because it's a nice technique that I'm going to show how to place the prosthesis before disarticulating. I need a little more room here. See, let me see the drill. Yartarka. Okay, don't worry, hold on. There, just like this, no problem, leave it. And then this handle I'm gonna lift up, a little up, so I have easier to pass instruments through here. Yartarka, you can leave this like this. And here is a suction. I'm going to take the suction out from underneath the laser. You can just put something over it, like a towel. Put something on top of it. No. Put something on top. Yeah, something over it. And then, where's my laser pedal here? And drill pedal is here. Hold on. Okay. Yartarka. And I know that I'm lateral to my facial nerve here, but I just need a little on this lateral side. I need a little more room. Just more to get the, just to get the laser in here at the right angle. Little water. Yeah. You see also how this micro drill, you see the micro drill is less stable, right? It's very, how can I say, it's very loose. It's less water? The micro drill itself is relatively loose. It's very thin. The regular drill is much more stable. So actually there's a benefit to using the normal drill and having more room to do it. Okay. There's a little bit of bone here I'm going to take out. No irrigation. Stop a second. Yeah. I just want here a little room to see better. Right here. And facial nerve is deep to me. I know because I'm at the level of the annulus, just about 1 millimeter deep. And the superior part, there's no facial nerve here. Okay, you can actually see the facial canal is down under here, quite away from me here. Just a little more here. So now I'm gonna have more room and take this back. Good. Let me see now the laser. Yeah, and now I'm gonna switch the pedals. Laser. Oh yeah. Good. Hello. Hello. I speak to you a little later. Yes. Okay. Sure. Thank you. Little Little focusing. There we go. Nice. You see? Sure. Once, but I'm actually doing. Yeah. Because I'm doing stapedotomy right now. So maybe after. So here, you see here. Yes, but I'm doing stapedotomy right now, so I can't. Sorry. Hello, good morning. I'm just doing the most delicate part right now. So so I'll show you. So I'm doing stapedectomy. So explain about what? I'm sorry. I can take a minute. About what about microscope? What about microscope? What about it? Oh.
This is Zeiss.
It's a Zeiss, I believe, is it Tivato? I'm not sure if it's Tivato or not, but it looks like. So I have actually, here is foot plate of Stapes, and here is the posterior arch, and I have laser, and I'm going to just clean this up a little bit more with laser. You see it? Now it's a blue light laser. Igor Rozena. Here's the facial nerve canal. I can see the facial nerve canal is right here. Okay, this is the facial nerve canal. So I'm anterior to the facial nerve canal. I'm between the facial nerve canal here and the pyramidal eminence. This is blocked. To clean it. No, it's blocked. You're welcome. Thank you.
Albo żeby pani przepłukała tamten. Jest ten moment.
It's very good microscope. That's the idea. Yeah, thank you. So here, look, so here is the Stapes superstructure. Yes. Here it's actually disarticulated somewhat here, okay? So there's something here.
Some kind of scar?
Yeah, some kind of scar. I don't know, maybe a Stapes mobilization was done rather than a stapedectomy.
Okay.
Yeah, and also, you notice how these flexible disposable, there's the foot plate, okay? You notice how these flexible disposable catheters are they're much softer stainless steel. The non-disposable, reusable, when you get to the very fine ones, are better.
Okay.
Because, do we have the metal one?
Mamy metalowe, to jest takie krótkie.
The very small metal one?
Takie malutkie.
Yeah, because see this, look, it's
moving.
very, very flexible. And the knot, yes, this may be better. Yes, see, watch. You're going to see that this is stronger. Yes, this is stronger metal. You just have to make sure it's not so big. This is very good. So it's a little bigger, but it's also stronger metal. So it's good to change. Now I have facial nerve canal here, and I have Stapes superstructure. So what I want to do, I want to make and measure stapedotomy and to do the placement of the prosthesis before disarticulation. Okay. It's more stable that way and secure, especially for this prosthesis. So, but I need a little more room just posteriorly. So I'm going to take the laser. Let me see the laser.
Teraz laser.
And just to give myself a little more room, I'm going to laser off a little bit of the back of the arch, but not completely. Just here, just a little here, just enough to see. Of course, we're going to laser this. We're going to break this off completely, but just a little to work. Let me see the Igor Rozena. See, just to give me another question. A little, the arch looks mobile because she had some procedure here, but the foot plate's not mobile. Okay, see, just a little bit. Now, let's see the prosthesis. Give me the Teflon, the all Teflon. Leave it just like this, and this like this. It's okay. You can put water on this, voda. And now you see I have this nice flat surface to work on.
Yes.
And yeah, it's okay. So it's wet. Yeah, it's correct. Now let me see the prosthesis and the measure.
Dobra, to teraz miarka i proteski. Proteski, tak.
Measure? Give me the measure.
Miarka.
And
Okay, which one?
let me see the all Teflon. Hold on.
Teflonowa, która to jest?
I'll show you which one.
Jest to z tej strony
This one.
światło.
This one.
Do you want a light?
No,
Nie,
I have
nie
no.
włączamy tego światła.
I'll take it. Don't open it. Yeah. Now I need a 15 blade and the igua rosena.
Igła rodzona i 15.
Now, so this particular prosthesis and method I learned from my dear friend, Professor Marcin Szymanski. But the modification of going through the keyhole from postauricular is mine. But the management of the foot plate, the arch of the stapes, and the use of this prosthesis is from Szymanski. Because in the United States, I had a gyrus smart piston, which was a self-crimping system with nitinol, and they're very expensive. So I don't have it here. Of course, it would be possible, but it's very expensive. Especially in Serbia, it's not really affordable to use such expensive devices. This is manufactured in Poland, Demed, and it's very nice and very useful. Do we have anything like a metal plate or something hard?
Mamy płytkę metalową, żeby podłożyć sobie. Może być też szpatuła.
No, it's okay.
Metalowa.
Something physical.
Is it okay?
Yes, this is good. Szpatulka. So I have something to cut up against. There, look. So now I have this. So now this prosthesis, we want to measure this to be 4.5 millimeters from the bottom of the loop. Okay, so I'm going to turn it this way, and so 4.5 millimeters from the bottom of the loop. That's the bottom of the loop. And, you know, we have to estimate what's the midpoint of the four. You know, this is not a razor thin marker, but it's okay. So let me see a 15 blade.
15.
So if I stabilize like this, and I put this to be at the top of this line. So now I'm at the top of this line. So this will be 1, 2, 3, 4, and 4.5 will be a little bigger because it'll be as if it was at the top of a line. So I'm going to go around, maybe around here, and I'm going to estimate it to be around here. Okay, so this is, if I go to the very center of the loop, it's still 1, 2, 3, 4, 5. Okay, so that was 5. I have to watch. Okay, so if I go to the very center of the loop, something like this, that's more at the center of the loop, then I can pull this in, still kind of at the top, 4.5, still a little bit on the longer side, then I'm pretty happy with that. So
Yes,
that's
now
4.5, 4.75, if I look at it. Okay, there. So if it looks too big, I will shorten it, but take that. Now, what you want to do with this prosthesis is you want to feed it down the barrel of the rosin needle, because we need it to stay open, and I don't want it to pop off and jump, but I need it to stay open. So we're going to leave this like this, and I'm going to leave it here right now. so that it doesn't fall away from me, okay? Now, let me see, suck. Okay, and I'm gonna leave it right there. Get rid of that so that it doesn't jump away from me.
Okay.
Okay. Now let me see, Klashiki Hartmana. Yeah, don't worry about it, it's good. Let me just see it, let me see that. Yeah, this is good. I just want to see. I have to make sure I have the proper, this is good. A small Hartmann Klashiki. Gonna leave this for me here also, okay? Good. Now, I'm gonna laser the foot plate, and we also want the drill ready. And the drill on the smaller burr diamond.
Najmniejszy diamencik.
Okay?
No to tylko wstyczną.
Let me see. You can give me.
This.
And this, if it's blue, it should be a 0. This is blue. You see?
Yes, it is.
It's okay. Yeah. This is blue. So this should be 0. I believe this should be 0. Oh, this is. But this is not a diamond. It's a cutting. Let me see the other one.
Jeszcze inne niech pani pokaże.
The other.
To nie jest diamencik.
I want a diamond. Okay, give me this. Give me this. Go. Give me that one back, and put that down to rotation 1000. So let's reduce the rotation to 1000. To 1000. Yes. Okay, 2 is the lowest that goes. Good enough. Okay. So it's okay. Now I just have to see. These are a little bit. Okay, it's in. Good. I just want to see. Okay. It actually is a diamond. It's a yellow diamond. It's a little. Give me the other one, the blue one. This is a little bigger. Yeah, the same. Isto. Okay. The blue, the smallest. No. This is green. No, I want the other one. The same one. Yes, this one. This is the smallest because this prosthesis has about a 0.5 size shaft. It's very small. So make sure that this is in. Okay. This is a problem with the use of these. Yeah, it's okay. It still works, but there. Now it's tight. I just want to make sure it's spinning. Hold on. It's spinning. Okay. It actually should be in a little deeper, but the system is a little off, but it's okay. This is better. Okay.
Is it okay?
Hold on. It's okay. This is better. You see now it's spinning. It's spinning stable.
Yes.
Right? Okay.
Yes.
Leave this here. Now I'm going to take the laser. Laser.
Laser.
Good. I'm gonna pull it back a little for more stability. Okay, there. Okay, there, just a little. Okay, so now, I want to up and see this. Okay, so right there. Okay, so I'm ready now for the laser, and I'm gonna put, where's the foot pedal? Good, here. So I have my foot pedal, nice, bloodless, you see? And right where it's easy to see, right where it's easy to place. I need a little more, I need a little more distance on my on my, there. Okay, a little more distance and there. Okay. Now, I went a little bit, I should have put it down to the 0, but it's okay, watch. Let me see the, do you have the straight pick, igła prosta?
Prostą igłę.
See, I didn't put it down to 0.01, I should, but I know it's okay because it's relatively thick and I didn't go through to the, I didn't go through and through, prosta igła, because there was no CSF. See, there. Now there's, perilymph. So I just cracked the perilymph, and that's going to be more than good enough. I actually won't need the drill.
Okay.
Because this is 0.4 with a little bit of extra energy. Now, I will take the, so now I want to see both the target and the incus, okay? Like this. Because this prosthesis, and why it's of benefit to have the let me just put it. I'll put it and then I'll explain after. Through and okay. Sometimes, see this, a suction, this prosthesis needs a little bit of work to get it over the incus. So that's why it's better to keep the joint intact and stable so that you can actually get it over the incus more easily. I may have to try again. To go in a little, and so if you have this in and get this underneath there, so this little movement of twisting it sideways was taught to me by Andrzej Zarowski because that's how he places it, and it's a very nice trick. You see, so now, because this all Teflon is a little bulky, it's a little harder to get it over the body of the incus in one smooth movement. But if you have a little difficulty and it starts to close on you a little, you rotate it sideways and then twist it over the body of the incus this way. Okay, so now we have it nicely into the stapedotomy, and I see it's nicely moving. So now we have to remove the rest of the stapes, okay? So I'll begin by lasering away the posterior foot plate. Let me just check. It's good size, it didn't go too deeply, and it's definitely in the hole. If it's ever so slightly, yes, I can see there's a slight bit of give around the hole, there's space, so that's perfect. Now let me see the laser. If you have a very small hole, you can just use one quick touch with the drill to make it big enough. But now we have a very nice placement. It's very stable. And now we will remove the rest of the superstructure freely and easily, see, because everything is in place now. So here, okay. Okay, let me see, igła rozena. No, there, okay, so that's free, and I can take the front part. So just crack the front part there, and everything is out. Okay, and let me see the klasziki.
Klasziki.
Okay, everything is out. You know, if you have difficulty getting it out, don't struggle. Just throw it down into the hypotympanum. It's not necessary to struggle. And let's check now again. Igor Rozena, and let's look at our foot plate, make sure nothing was subluxed. If it is, it's not a problem if it was dislocated partially because we have the prosthesis in position. See a smaller suck?
Mniejsze stanie.
Just gently with the finger off the hole, not to suck the fluid out, but I want to see the foot plate. A little bit of blood is good, but I want to see. Okay, not a problem. I see everything is in good place. Here's the back part of the arch, and I still see the edge of the foot plate. So this is all off without a problem. Okay, I didn't pull out the back edge. Why it's important to look is if I pulled out the back edge, then I have to make sure I pack more tissue around it, not to get a perilymphatic fistula. So this is nice, this is satisfactory. And I will take a little bit of tissue, pincet, yes, anatomic, and małe nożyczki.
I małe nożyczki.
We have plenty of tissue. We have fat, you know, a little fiber of fatty tissue is good. A little fiber of fatty tissue from the wound is perfect. Normal nożyczki, like, yeah. See, so here's fiber of fatty tissue.
This and this. Takie albo
Good. This is good. They can take all the oh no, not yet, hold on. Here, and I'm gonna take that, and a little second piece. Okay, and let me see Igor Rozena. Igor Rozena desno, levo suck.
i stanie.
Yeah, good. And I have a nice view here. Again, you see, take advantage of the depth of field afforded by pulling the focus out. Then I'll take this and put this rather, here they are. I'll put this here. It's a little big, but it's okay. Let me see a 15 blade. Good. Igor Rozena. So I like to put one up over the top first because it's harder to get the top one in. A small one over the top. It's, where did I put it? I put it here. Some people with this prosthesis don't pack at all. I still pack. I think it's reasonable. And the other piece is, this is bone. Don't want to put that there. A little piece in the front, a little piece in the back of the foot plate. There is blood, so that's okay. Just enough, not too much. And here, where did it go? Okay. So reasonable to put a little soft tissue. And then let me see that cartilage, the chrząstka. Chrząstka that you gave me before.
She was waiting for this.
It's a chrząstka, right?
Perfect.
Dzięki. Chrząstka. Good, excellent, excellent. So, chrząstka, let's see. Let me slightly bigger sania.
Większe stanie.
Saniak or sanya? It's a little big, so I'm going to cut it down with a little 15 blade. Let me see. 15, nož 15. See, look, just a little bit to recreate the back of the part that we removed. Yes, and good. I have plenty of tissue here. And a little bit of perichondrium to go underneath the eardrum to reinforce the part that was. There. Okay, so there. Plenty. Okay. This should be good. I'll save the rest. Never throw anything out until you're completely finished. Okay, and okay, good. And I have, here's the knife, here's the igua rosena. And I'll take special note, you know, in the dictation of what I removed, what I put, because if she does go to cochlear implantation,
Okay.
we'll know what to look for in the posterior tympanotomy, you know. So here now I have this. This is good. Maybe I can break this a little here. There. Crack that. Don't have to remove it, but I can crack it so it folds, you see. Good. This is very nice. And that's it. Now I'll look through here. Take this, Shanska here. Now let me see the Zernik za ucho. And watch this. I'm going to take a little bigger suction. Oh, this is okay. Actually, this is okay. And watch. Now watch. Watch. Here. I'm going to look here. Yeah, większe. And I'm going to put this here. So here's the ear, right? Here's the ear canal. I'm going to put the suction in. I'm going to put the suction here and suck this down. Watch. There, see?
Yes.
It sucks down, okay? And I can close this, and then I can suck this down and then put just temporarily a little bit of a gauze, just temporarily. So I can see that this, just to suck this down like this. That's it. And it's pretty much closed. Good. Now let me see, we can turn off the laser. If you want, she can hit this button that says ready, turn it off. Good. See, now it's off. Good. Good. So now let me see dissolvable suture like a Novacin. You have Novacin Vicryl, and then to close Monosin. No, don't need, no. But if you don't, yeah, good. Yeah, just suture. 3.0 ili 4.0. 4 ili 4. Ili is or in Serbian. How is it in Polish? Or. Or.
Albo.
Algo? Okay, algo.
Albo.
Ili is algo. Okay. Pincet chirurgic. Da, good. Okay, now hold this up for me just like that. Good. And I only need a very small, I only need 1 or 2 like this. Actually, I can go a little deeper here in the deeper tissue. Huh?
Do you want to put soundtrack with antibiotic
No.
inside? No.
No,
Yeah.
nothing. Look, one like this. I'll let it. One like this is enough, and then the
Okay.
skin with monosen. Nożycki.
Nożyczki.
One deep to close it up, and then here, and then monosen.
I teraz monosun, dobra? Na skórę. Ale monosun to robi specjalny. Tak.
Monosen. That.
You want absorber?
Yes. Yes.
I do drugiego tak samo. Tak.
And gazik.
I gazik jest.
Oh, here's the needle. Here. Sorry.
Igła.
Igła.
Tak.
Gazik and monosen. And watch. Dissolvable. I'll use dissolvable monosen. Good, just like that. Good. And
Umadło?
imadua. Da.
Tu mam.
Oh, iba. Da. What size monosen is this, curiosity?
This is 4-0 or?
4-0 is okay.
4-0.
Yeah, it's okay. But you can even use 5, but it's okay. 4 is okay. Children a little smaller, but when you see them in follow-up at about 10 days, or you can even wait. Actually, the other advantage of doing this, Nożycki, you can see them back at a month. You don't need to see her unless she has a problem. So at 1 month, you can see her. And if this tiny little suture is still bothering them, you can just cut the little tail. But they can get this wet tomorrow. I let them shower normally, and I don't do subcutaneous. It doesn't make any difference at all.
Right.
It's the subcuticular is more difficult. It takes a little longer. And for me, I find it annoying.
Okay.
And the difference in healing from this little running suture versus the subcuticular is actually, if you think about it, if you do a subcuticular, you're actually putting more foreign body under the skin.
Yes. So it's even better.
I think this is better, the little pieces, and this is a completely invisible scar in the end anyway. It's right in the crease.
Yes.
For regular tympanomastodectomy, I don't go in the crease so much because I want a little better closure, but for this, with this little keyhole approach, I go right in the crease so the scar's completely hidden.